Welcome to the Go-To Physio show. Coming up on today's show, we take you through how to do a real-life hamstring assessment with even the most stubborn hamstring patient. Also coming up in today's show, I show you one of the best exercises that I use from day one post-injury. We also show you how to tackle a patient that's maybe had recurrent hamstring or recurrent injuries and how to build their confidence back up again. And I also share with you one vital thing that you need to do if you want to grow your practice to become that go-to therapist. I hope you enjoy the show. So welcome to episode 7 of the Go-To Physio show. Now in today's episode, the main teaching content I want to cover is starting to clinically reason, your objective assessment. So hands down, the biggest mistake that I see, especially when I used to get kind of final year students and even new grads coming into the professional sport environment and I get them to do an assessment, is they just bang through the assessment, There's no higher level thinking or clinically reasoning as you go through your assessment. So your assessment, it should be on top of everything. Every single thing you do should be adding to your kind of working hypothesis that you've had from the subjective assessment, What it sounds like, previous injuries, how have they impacted that, etc. And again, you can go back to previous episodes to get more information on that. But the biggest thing that I want from my hamstring assessment is I want to know what are the 80-20 rule, What are the 20% of my attention is going to be in desensitize these tissues, but most importantly, 80% of my attention is going to be focused on what I think has contributed to this pain experience, So that's the very, very critical point that I want you to get this week, Anyone can massage a hamstring, anyone can give Nordics, Anyone can get that athlete back running again, But the shit will hit the fan, when that athlete's back in an uncontrolled environment, And that's where you need to make sure that that true stressor is being addressed as to why this hamstring, why these particular fibers got overloaded, got stressed, whatever you want to call it, in the first place, So your assessment wants to build on that, Now in the last episode, I talked about using a constraint-based approach, And then I also talked about a little bit about the slump test, So you want to be going through all your generic assessment stuff, Again, we've got 3 layers in our therapist mentorship that we use, And I'm going to show you a little bit about how I would apply that in the regards of hamstring today, But your assessment will want to build on top of each other, So I would have done what I call my generic assessment, looking globally before this point, So for this hamstring, what I want to know first and foremost is there genuine trauma to these hamstring tissues, Is there genuine trauma to the muscular fibers of this hamstring, And this rule of thumb, it's clinically, it's been very, very useful for me, And there's a couple of exceptions where it may not hold true, and I'm going to cover those at the end of this piece. So Pete, if you actually tell you what, we can have a look at your generic stuff like your straight, like raise and your tension, etc. But as we've said already, we can eliminate neural tension very, very quickly once we focus on the tissues that are going to contribute to that neural tension, And again, the diaphragm pelvic floor, if it's a person who has had a lot of stress recently, either physical or emotional, the impact that that's had on the respiratory system, is that sensitized that? Has that decreased the amplitude of movement through the diaphragm and pelvic floor? Because they're increasing their respiratory rate, they may be going towards that mouth breathing that you're probably seeing in the clinic. But again, the mouth breathing is not the true cause, It's a reaction to the stressor that's specific to that person, But one of the best tests that I've got, if you now lie in your front for me, Pete, and we've got Pete here, one of the therapists at Huddersfield Giants, and he works in my clinic just agreeing to model for this, is the actual intent through a resisted test. Okay, so what I will do first and foremost with my patient, okay, to see what I'm dealing with here is I'll do the knee flexion test, okay? Now this you probably do yourself, but what I'm looking for is a higher level of thinking here rather than just going through the motions and doing these tests. So what I'm going to ask Pete to do is I'm going to ask Pete to push his heel to his bum. So Pete, push your heel to your bum for me, okay? And I'm just going to give him a bit of resistance down. Now, if this is straight off the field and it's quite acute, you will start quite low, maybe 20, 30, 40% your perceived maximal voluntary contraction or pressure through your hand. Okay, so Pete, push again. Okay, push, push, push. And what I'll do with the person is I'll egg them on a little bit. Okay, so what I want to see here is intent. Okay, I want to see, is Pete got the intent to really push into my hand, or is he very tense and cautious? Okay, now if Pete's cautious, I very much perceive that as subconsciously Pete is guarding these tissues, okay? Now, on the other hand, if Pete's got really good intent, then that, I would interpret that his subconscious is very happy to load these tissues. Now, Pete still may get a pain experience, okay, and that's fine, but intent, and he's got a strong kind of end feel, okay, or we can feel real good power here, then I'm a lot more confident that there may not actually be specific trauma to these tissues, that this may be more of a perceived threat as opposed to an actual trauma. Okay, so Pete, push again for me. Okay, and Pete's good there. He can hold that isometric. Just understanding what's happening here. When I put Pete here and I push here and Pete pushes there, yeah, he is concentrically contracting, but there's going to be a point in this test where this hamstring is going to work isometric. We're very much focusing on the knee flexors here. Now, consider here is that the gastroc also is going to contribute. So what we can do now is we can actually see how much of that test is the gastroc contributing to. So what I'm going to do here with Pete now is I'm going to shorten his gastroc by plantar flexing. So when I plantar flex Pete now, we're going to put muscle slack into the gastroc, which makes it a little bit harder to produce the same level of force. Okay, so now with that plantar flexion, let's see the difference. Okay, so push your heel to your bum, Pete. Good. And again, he can maintain that. Okay, so good stuff. So again, you may use that information, okay, with plantar flexion. Does that increase his pain experience? Does that take his pain experience down a little bit? Okay, and we're going to start to use that information as we go through the test. Now, that test, it's looking at putting a load in this direction here, okay? Now, if I want to put a load in the posterior lateral direction, then all we're going to do is we're going to externally rotate the hip a little bit, and we're going to do the same thing again. Okay, Pete, push again for me. Good. And then the big one for me, okay, is we want to put a load through the posterior medial tissues. And you're going to see this in the lit review in a little bit, about the importance of these medial hamstrings. Okay, so what I'm going to do here now is I'm going to internally rotate Pete's hip, and I want him to push his heel to his bum. Okay, and a lot of people, and Pete's got a little bit of that here. Perfect. Okay, and again, I hadn't assessed Pete before this. So if you push your heel to your bum again, Pete. Okay, and Pete really struggles with that. Okay, so my interpretation of that, okay, I'm putting a force here. Pete, genuinely, how much force am I putting through? Okay, so I'm putting maybe 20, 30, 40% through here. I'm asking Pete's nervous system to match that, and ultimately what I'm looking for is an isometric contraction of the medial hamstrings. Okay, so I've got good clinical information here. Now, is this relevant to Pete? His pain experience, his injury history? We'd have to understand all that, okay? But that tells me struggling to isometric conditions when we need them to, and as a very, very maximal loading. Okay, so again, these medial hamstrings are going to be very, very important. Okay, so again, you look at Nordics and you look at the amount of activation that Nordics give the medial hamstrings. Okay, then maybe are we starting to look at Nordics a little bit differently? Are maybe Nordics effective because they're actually restoring intent through this direction? Okay, yeah, sure, the fascicle lengths are changing in biceps femoris, but what else is happening? Okay, is the reason maybe that the biceps femoris took a little bit more load because maybe the nervous system knows, actually, you know what, this guy here is not very efficient at the moment putting load through that medial hamstring. Now, yes, I appreciate before the comments come, how can you make an assumption between on the bed and in sprinting? I get that, totally different context. But on a spinal cord level, Pete needs to deliver, okay, an ability to use this under isometric load at this moment of time, and he's struggling to do that. Now, from my clinical experience, when I put Pete into standing and I put him in positions that's going to bias a load going through that medial hamstring, I usually will see something that will correlate with this. Okay, and this is clinical experience, this isn't studies, and it'd be pretty much very hard to apply that, but we can put him in positions on his feet later in our assessment to really see, is this contributing? Okay, and again, that medial hamstrings, okay, very, very important for meniscal issues, and obviously for the ACL as well. Okay, so that's something, okay, that I just want you to look at and think about. Okay, so if I do all my soft tissue work here, and yeah, geez, he's really here, brilliant, he's flying here, pain free, he's sprinting well, but then I go here and in range, he still can't overcome muscle slack, work these tissues isometrically. Are we giving him the best chance anytime he's in this position? Okay, so when he's in this position about to cut and change direction, okay, my glute, okay, there's a lot of slack in my glute here, okay, my biceps femoris is also a little bit shortened, so the tissues now in a better position to fire will be my medial hamstrings, my adductors, okay, so but do I have intent to load well through these tissues? Okay, so again, these are just some questions that I ask myself. And again, clinical experience over 10 years of working in professional sport, this is the stuff where we're going to start to see some things on the bed, and we'll also see it once we get them into the higher level issues. Okay, and it was only when I was starting to see this stuff on a higher level, okay, when we were putting them into change direction positions and the real lack of intent pushing off the foot in these positions when the hamstring and the glute weren't in, you know, good length. That's what I'm talking about from a constraint-based approach last week, okay, with our level of loading. All I want to do from a low level loading at the moment is give Pete back the intent to work this medial hamstring, okay, at a 40, 30, 50% max voluntary contraction. Okay, we want to show his nervous system that it's safe to tolerate load through that. Then we want to build them up, okay, we want to get them in standing, and then you can start to increase the loading through stuff like Nordics or whatever you're doing as well, okay? But my first session, my constraint-based approach here, is let's take care of this, okay? So now I've got a key performance indicator that when I give them something later on, I'm going to go back and check the next session. That's one of the first things I'm going to be interested in the next session. Has he got that now? Great. And just because he can do that now and he's got good power, that doesn't mean that he's ready to go back into running, change of direction, sprinting. It just means that he can do what I've asked him to do there. So what I want to do then is I want to challenge that loading a little bit more, and I want the medial hamstring to work with the medial gastroc, be a plantar flexion of the foot into ground reaction forces, and I maybe want the torso going over that way as well, okay, as if he's about to tackle someone or change direction, okay? So that's the first test. Okay, and again, we've got a lot of information just from one simple test by just changing the direction of force. Okay, it's taught me an awful lot of things that I want to bias when I'm doing a lot of my co-contraction work, my lunge work, a lot of even my RDL work, even the Nordics. Okay, and I can do a Nordic and I can bias this direction more than the lateral hamstrings, okay? If you understand the reactions that happen through the body, that's very, very easy to do. I've got a problem here, and I've got an exercise that I can modify to bring a solution to that problem, okay? And that's very, very powerful, rather than just throwing shit at the wall, doing your Nordics, and hoping for the best. And sure, yeah, Nordics will fire that medial hamstring, brilliant, and it's a really good exercise for the medial hamstring, okay? But we just want to maybe integrate the torso position a little bit more, because person does not walk around like this, okay? Person doesn't play sport like this. There's going to be times where the torso is going to be different to in a different position, different planes, to the knee, to the foot, to the hip, etc. Okay, so that's the first test, okay? So just to kind of summarize my point, now I got a little bit off track here because we found something with Pete, okay, is now why Pete has an inability to push or use that medial hamstring isometrically, okay, unless Pete's had a previous hamstring injury or something like that, okay, then that may not be the true cause of why his brain does not want to put load through this at the moment, okay? Have you had any previous hamstring injuries, Pete?
Yeah.
On this side?
Yeah, on that side, yeah.
Okay. What other injuries have you had?
Ankle sprains as well.
Ankle sprains. Okay, cool. So again, let's start hypothesizing here, okay? So he's had, and I think this ankle is pretty bad, isn't it, if I remember from mentorship. Okay, so if Pete doesn't want to load his toe, okay, after an ankle sprain, and he's got less than 10 to that big toe, is he going to load his medial gastroc? Is he going to load the medial hamstring? Okay, or is he still avoiding loading that due to a previous injury, a motor adaptation? Go back to episode 1 and look at how the body works around perceived threat or nociceptive, excessive nociceptive loading. Okay, so I don't even know if that was the right term to use there. I'm sure some Twitter guru will come at us. So that's the big thing with that is what I would do in this scenario is I would link that, why is Pete not loading that medial hamstring? Okay, I'd look at his previous injury history. Maybe we want to look at that. Maybe we want to look, is there some sensitized tissue here still? Okay, so that's the big thing with that. So this test, to summarize, all we're doing here is we're looking at these tissues, okay, with very, very little hip, okay? So if this person had a pain experience, okay, or they had a little bit of pain, and usually with a lot of these kind of non-traumatic hamstrings that you're going to see in the clinic, and even more persistent hamstring issues, okay, is that they'll say, yeah, I just feel a little bit here, but it's not too bad. They'll have good strength, good power, okay? So that to me is very encouraging, okay? So then I'm going to start to build my working hypothesis. Yeah, I definitely want to check the different directions, see if there's a problem. But then what I'm going to do with Pete is I'm going to pull him on his back, okay? So if you lie on your back, Pete, and then what I want to do is we want to see what Pete's like when he actually loads that hamstring under isometric conditions, okay? And we also get the hip and the gastroc involved a little bit, okay? So what we'll do then is we'll just use a simple bridge. So all I want Pete to do is I want you to push down onto my shoulder and bridge up for me, okay? Good. Good stuff, and back again, good. And what I'm interested in here in particular is what's happening to this knee, okay? So a lot of athletes, they'll be able to stabilize the knee and they'll actually be able to lift from the hip. So I want to really push down through my shoulder, Pete, and lift. So we'll see there's not a massive amount of extension here from Pete. If Pete's inefficient, okay, at co-contracting at the knee, and especially at the medial hamstrings, what will happen is as Pete bridges up. Now I'm going to do this myself, just so that you can see it. And there was a little bit initially with Pete, but I'm going to exaggerate it. So if you bridge up again, Pete, okay, you'll start to see that knee will almost go like that, okay? So you'll see that they might start to slide their calf a little bit and the knee will start to extend. So what that's telling me is, as they're bridging, is they're trying to almost avoid loading the distal hamstrings, okay? So again, if you push again, Pete, okay, and back down again, and just do that again. Okay, and Pete's actually doing something pretty funky here, and genuinely, I'm not telling him to do this. So if you watch this, so Pete, go again. Okay, so you can see Pete actually starts to externally rotate his hip as he does this, okay? So if you do it again, okay, so you can see that kneecap hopefully starts to go this way. Go again, Pete. Okay, so it starts to rotate. Okay, so again, Pete's very good loading through this lateral hamstring. Now let's internally rotate his leg. Okay, so that's going to shorten these tissues. It's going to put these tissues in a bit better position to overcome muscle slack, and he's going to have to use his medial hamstring. So if you bridge up again, okay, good, and back down again. And just watch that little pause where he tries to figure things out. And I'm going to really exaggerate. Okay, bridge up again. Okay, so you can see that it's just not smooth, it's just not coming up. Okay, so he's almost using a top-down approach here to do that again. Okay, bridge up again. So what I'm looking for, okay, now let's do the other way where he's good. Okay, let's bias this lateral hamstring, so bridge again. Okay, he just goes straight up. Okay, so just look at the smoothness of that. Okay, so that's what we might see clinically, a top-down versus a self-organizing system where he's got it, or he has to really use a top-down driver, okay? Because again, he has to override his spinal cord, okay, here, where usually when he just does this, he can just think about it, okay? Give him an outcome, bridge up, Pete, okay? Everything self-organizes. Spinal cord to peripheral tissues, they'll do their thing. There may be a perceived threat here at the moment where his spinal cord is not too happy to load these tissues, okay, based on previous experiences. So Pete has to top down, override it, and really focus on pushing down through my knee. Okay, so do again, I'll push down through my shoulder. Okay, so he has to think about that again. So again, we're looking at that. Can he hold that knee flexion as he bridges? Same again. Okay, good. And you can just see he starts to rotate a little bit. And then obviously you can test this hamstring at different ranges. Okay, so I like a slight bent knee. Okay, just as about that foot's about to hit the floor, that length tension relationship, and then bridge again, Pete. Okay, and you can see he likes to load. So if you can keep this leg straight, Pete, just so they can see your leg. Okay, and if you bridge again, you see he loves going to that external rotation. Okay, so now if Pete had a pain experience here and he's like, shit, that's my pain. Okay, now this is starting to make sense for me. So you can see Pete's using his hip external rotators excessively here. Okay, so maybe are these tissues and the biceps femoris going, hey, we're doing a lot of work here. Let's send some information to the higher centers. The higher centers get sick of hearing that and going, you know what, I'm going to give you a pain experience. I'm going to give some kind of tightness, some kind of unpleasant sensation, or I'm going to give some kind of warning. Okay, so that's why these patients that come in and you're like, oh geez, if they torn their hammy, you lie them on the front, bang, very good power in that situation. But then when you put them on their back and they have to use that hamstring more isometrically, they have to transmit forces to the hip. The hip also has to work with the hamstring. That's then where that pain experience tends to intensify, because they're the tissues then that I would hypothesize are contributing more significantly to that pain experience. So then for me, I may want to desensitize, okay, my 20% here will be desensitizing maybe the deep rotators, okay? But what I would do with that, previous to these tests, is I would have gone back and I would be looking for more clues. So again, is there any protective tone in his hip flexion that's telling me that he's got some kind of protective response here, okay? So again, his hip flexion feels a little bit stiff. Maybe he's actually using his external fibers of glute max here, okay? Are they a little bit protective in nature? So we might want to desensitize those tissues rather than just sticking our elbow into the glutes and hoping for the best. We're using our passive assessments. We're getting information from our assessment. Then we're going to desensitize these tissues. But 80% of my rehab for this scenario is going to be geared towards that medial hamstring, or I might have to be geared towards the ankle, okay, to give that intent to send forces through the medial gastroc to send it up into that hamstring as well, because they're going to work synergistically together, okay? So a lot of my actual rehab for this guy may be loading his medial hamstrings. Now, luckily the Nordic's going to get that, but I might want to consider the torso position as well, okay? So that's just something, a little bit of an insight into how my head works, okay? Now, disclaimer, this isn't the only way to get your results, okay? This is the way that I look at the body, okay, and that I'm sharing with you today. The beauty of our profession is that there's more than one way to get to the end goal, okay? So that's kind of my thought process that I look at when people come into the clinic here, when pro athletes come that have had persistent hamstring issues for a long time, okay? We look at that, we find the 80%, and we start to clinically reason, we integrate it into the patient's story, and we start to make sense of their story. We take the full assessment, we start to make sense of that, and then we break it down into our 80-20. 80% true stressor, 20% desensitize. Okay, we still have a little bit of desensitization to do for Pete if he had a pain experience through his hip tissues and probably maybe actually through that biceps femur or wherever. Okay, but the 80% will be going either towards the medial hamstring, the gastroc, or whatever. Now, I've got a lot more work to do now with my assessment to really dig deeper, okay, to dive deep into finding those true stressors. And I'll put him into some positions where he has to really generate torque through the medial hamstring, the gastroc. At the moment, I would go towards the ankle probably. Okay, I'd go to Pete, what happened first, your ankle, your hamstring, and then we'd start to get the intent back through that big toe maybe, okay, which is going to load his peroneals and his medial gastroc nicely, okay, and then that's also going to help recruit that medial hamstring as well from the bottom up, okay, using ground reaction forces through that, okay. So I hope that made sense. As I said, look, this is just one way of looking at the body. You don't have to do it like this. If you've got other ways, okay, that's absolutely fine. I respect that, okay? But this is the way that I've developed my thought process based on my experiences, based on my world of having professional athletes come in off the field and having the pressure where we have to find that true cause very quickly. And again, I'm hypothesizing the true cause here, okay? But luckily for me, 9 times out of 10, and you know, probably a bit more than that the pain usually doesn't return, okay? If we obviously manage their loads well and we get them moving well in the gym as well. So there's more to it than just that. We have to go through that loading, and then usually we get that we get that good outcome with the patient because we've actually given them back an ability to send direction or loading in every direction. Okay, so that's what it's all about. It's not about giving the patient anything new. I'm not coming in here as the hero. Okay, again, look at episode 2. I'm coming in as the guide. I'm just giving Pete back, or I'm guiding Pete and helping himself get back a tolerance to loading through that posterior medial direction. Okay, as I said, I think a lot of hamstrings, okay, they get a lot of benefit from Nordics because we actually get that medial hamstring doing a little bit. Okay, so it's worth assessing that medial hamstring. In a lot of cases, especially knee pain as well, I see that medial hamstring, in my opinion, it's probably more important than the hip. Okay, so again, it's close to the knee, takes care of the meniscus, it has to overcome muscle slack. When that knee goes into a valgus, that medial hamstring is in a much better position to overcome muscle slack, but we need good intent. And we need the ability to tolerate load through there. I said there's a lot of other tissues that go up there. The adductor canal goes up there, the lymphatic system, okay? So there's a lot of stuff close to that medial hamstring there as well that may influence it. As I said, I'm not quite sure why we see a lot of this at the moment, but clinically that's a tissue that I'm very interested in. One exercise that I think a lot of athletes would benefit from, regardless, okay, of whether it is a genuine trauma to the tissue or whether it's maybe we think that something around the hip, etc., is contributing to this pain experience, is an exercise where I like to get the athlete pushing through the midfoot, okay? And I would do this exercise pretty much day 1 after an injury, okay, as soon as possible. So what I'm going to get Pete to do, and it's very easy, is Pete, I want you to imagine that there's an orange under your midfoot here for me, okay? Now I still want your toes to push through the floor, but I want your intent to push through the midfoot for me, okay? And all I want you to do, Pete, as you inhale slowly through your nose, is I want you to build tension, okay? So imagine that there's an aeroplane taking off and you're just building tension through the floor. So I don't want you to go from 0 to 100. I want you to take about a good 4, 5, 6 seconds, let's say 6 seconds, to build up to that point where you feel you have your contraction, okay? If you get any pain, I want you to just go below that pain level at the moment, okay? So Pete, I just want you to push through. Now what I would do sometimes is I would actually put my hand under that midfoot to give them that proprioceptive awareness. Now squash an orange, Pete, and I'm gently just going to lift a tiny bit so that he has to push, okay? A lot of people, they're going to be used to pushing through their heel, but we want that intent through the midfoot, okay? So push through the midfoot again, Pete. Build tension. Good. Now, a lot of athletes, what they're going to feel like, okay, my hamstring feels like it's going to cramp, or they might say something like, I can't really feel it anywhere. I feel it in my calf, okay? Now, the whole point of this exercise is that I want to give Pete back options, okay? So when I get Pete to push through the heel, okay, we're going to bias usually the hip, okay? So if you push through the heel, Pete, what we're going to usually feel is the top of the hamstring. Can you feel it working there a little bit? If I push through the toes, we're going to generate a torque predominantly around the quad. So if you push just through the toes, Pete, you feel like this is going to start to work. Whereas the beauty of this is if I push through the midfoot, I'm going to get the hamstring to generate torque. I'm going to get the gastroc to generate torque because that's going to stop knee extension. But yet, we're still going to have some bit of quads working, and we're going to have some bit of hip extension. So it's a nice exercise just to get everything working together again, restore and reassure the ability of the whole system to generate torque, because I don't want one muscle to generate torque. I want everything to generate torque to help and do its job based on the demands that's being placed upon the body in the here and now. So this is a good exercise because as we push through that midfoot, the hamstring's going to have to generate torque. It's going to work under isometric conditions at about 5 or 6 seconds as Pete continues to build tension. And then what we want ideally is we want to feel tension in the glute as well. So we want Pete to be able to generate tension here. When that hamstring's working isometrically, then hopefully it's going to start to transfer some energy up into that hip. So just build tension again, Pete. And again, the athlete day one post-injury, or even if the athlete's come into me straight from the training ground and he's done this like literally an hour ago, I will usually give him this exercise pretty much straight away to start with. Now this is good because it just reassures the system that it's safe to put a force through the tissue ASAP again, okay? And very often then what we'll find is he can build a bit more tension. He can do it without cramping, or he can do it without pain. If he gets any cramping through the hamstring, etc., he's probably putting too much force through it, or we need to build up the tension slower. So it's giving us a lot of good awareness of these tissues again. It's bringing back his awareness to the tissues. He's getting a bit more feel of the tissues co-contracting rather than one tissue working excessively. So it's a brilliant exercise that I really, really like. It looks very, very easy, but don't underestimate the power of this exercise. Now, in the mentorship, we might make it a little bit more specific depending on what we find with our assessment and a bit more in depth. But certainly for now, I would encourage you to use this exercise with an acute hamstring injury because it works very, very well. And even with more of the persistent cases, just even starting at this level and reassuring the brain that it's safe to push through the floor and generate torque in all different directions. Because in that scenario, his calf, his soleus, gastroc, hamstrings, quads, glutes, they're all going to work together to generate tension. And having that low level, submaximal building tension from a mindfulness point of view and giving him awareness of these tissues is very, very powerful. And then the other thing that I get Pete to do is I get him to inhale slowly, okay? So Pete, I want you to slow the air in through your nose as you build tension. So as Pete concentrates on the air coming in through the nose, we just bring a bit of mindfulness into it, which will hopefully then dampen down the limbic system as well. That could be contributing to this threat response that's ultimately contributing to this pain experience. So welcome to this episode's Build Your Business. Now in this episode I want to talk about one of the very first things that has to happen even before we get the subjective assessment out of the way. And it's something that I just want to bring your awareness to, okay? And you're probably already doing it at the moment, okay? You're doing it really well with some people and you're probably really struggling with other people. And that is building a connection with your patients. So what I want you to do this week in this episode's Build Your Business is I want you to bring your awareness for the remainder of this week and until next week's show is what do you do well when you've got a good connection with your patient, okay? So I want you to think about the times when you've got a great connection with that patient, and I want you to bring your awareness to what you're doing really well. What are you saying? How are you acting? Are you more relaxed? What are you talking about? And then I want you to look at maybe one or two patients where you just feel like you don't have that connection with the patients. And I want you to bring your awareness to your behavior, your thoughts, okay, what you're talking about there, okay? Because building connection is the very, very first step, okay? And this is not only a business tip, but it's a clinical tip as well. Because if we've got a good connection with that patient, they know, like, and trust us to a point, okay? And obviously we can't get to know, like, and trust them too much, okay? And I'm not saying tell them everything about your personal life, but we've got some kind of connection, then they tend to relax, they tend to trust you a lot more, okay? They're going to listen to you on a deeper level, they're going to commit to the program, okay? They're going to follow through and probably not drop off, okay? Which we'll talk about next week. And there's a lot of good things happen as a result of doing one simple thing, and that's building a connection with your patient. Now, building a connection with a patient, it's going to be very, very easy if you're somebody who likes rugby league, okay? So if someone who comes in and they're a big rugby league fan, to me, that's obviously something that we've got in common, okay? We can build that connection of, you know, chatting about rugby league. But someone who doesn't have the rugby league common, or might be Gaelic football or hurling for those in Ireland, or some other sport in some different country. But for those patients that you don't have that in connection, you still have a lot of things in connection. So for instance, a patient who has a young girl, okay? She has a young daughter, okay? I've got a young daughter, so we've got a second degree connection there that can just help break down the barriers a little bit, okay? So again, almost bring your awareness, okay, take a step back and bring your awareness to how you're connecting really well with a lot of your patients. And the thing that I think you're going to find this week that you'll be pleasantly surprised with is a lot of the connection is built. In fact, I would go to say 99% of it's built based on non-clinical stuff that you're doing, you're saying, and how you're reacting, okay? So for a lot of therapists, you need to relax, you need to look the person in the eye, you need to listen to them properly, okay? The patient wants to feel like they've been listened to, you want to have empathy, okay? They're all things that's going to help build that connection. And then how you build connection with a specific person, obviously you're looking for bits with those as well, okay? So that's the first thing, build a connection with the patient. They'll start to relax, they'll move a little bit differently, they'll trust you, you'll get the buy-in, hopefully the adherence, that will all come on the back of that, okay? If you've no connection there, as you're explaining your findings, your pain science, whatever, you're explaining what you need to do. If the connection isn't there, then and I certainly have had a few that comes to mind early in my career where the connection just wasn't there, and they may go see another therapist and they may have delivered the exact same program, but they've got a better connection. The outcome often is very, very different. Okay, so there you have it for this week's Build Your Business. A little bit of homework, bring your awareness to the connection that you have with some patients, what you're doing, what you're saying, how you're acting, versus maybe some patients where you don't have that connection at the moment, okay? So they're the patients then where you may start to change your thought process, you may start to change your behavior a little bit, and hopefully then you'll start to notice a bit more of a better outcome once you start to look for those second or indirect connections that you have with that patient. The Therapist Mentorship Program was put together to help you accelerate your ability to have confidence and clarity with any patient that comes through the door. It's a very intimate 90-day experience where you work closely with myself and my most trusted therapists to put together a very, very specific structure in your assessment, your treatment and your rehab for every single patient so that you can truly get the results that both you and your patient deserve so you can become that go-to therapist. If you want more information, just click on the button below this video or go to thegotophysio.com/mentorship.
I was a new grad, looking to further develop my skills and get into the industry. A little bit apprehensive, that's why I chose to join the mentorship to further my skills and education. Don't get me wrong, university taught me a hell of a lot. The treatment techniques, the theory behind everything were perfect, but they don't teach you the real life scenarios. So everything at university was sort of this happened, what we do with this, this and this, and a protocol for that. Whereas in real life, you're seeing the patient in front of you, everything's not straightforward. You might have a little bit of sort of overlapping pathologies there. So going on in the mentorship, going towards that, I just wanted to further my confidence, my clinical reasoning, and a little bit more theory and skills behind that as well. Really easy to follow. So for each month of the mentorship, it brings out new content of different joints. So within the joints is the testing, the treatment, diagnosis and so forth, rehab. So it's just easy to go back onto each subject and see what you need as well. So within each sort of month as well, there's PDF sheets for tests and stuff like that, so it's quite handy. So if you're in the treatment room with a client or in any scenario with a client and such, you can easily just have a look at sort of the videos, the PDF files, and just give yourself a quick reminder of how to test the muscles or treat in that way. It's helped me 100%. So coming into this field, graduate from university, like I said, university taught me a lot, but not in real life. So once in the real life world and scenarios, not going to lie, I was a bit nervous. I didn't think I was going to treat and get the patients better. From the mentorship, applying the techniques through there and the confidence that it's given me, I'm confident now to treat the majority of patients. I'm going to get them better. Be serious about developing yourself as a clinician if you want to further your practice and just better yourself.